Hello, everyone. Hello, everyone on Facebook. Thank you for watching. Hello, everybody on Instagram. Thank you for coming. So excited. Happy Thursday. Today's live training is part one of the Business of PT series that I will be doing for the month of March. So thank you for coming today. Today, we are going to be talking like all things billing, right? So CPT codes, the differences in the different types of treatments that we can do. We're going to talk about Medicare's 8-minute rule, the dreaded 8-minute rule. That's very confusing for a lot of people. And we're going to talk about how to split up those minutes in a treatment session so that you're billing them correctly, okay? So for those of you that do not know me, I am Dr. Jody Miller. I'm a physical therapist in the Tampa area. I'm also a mentor to PT students and new or newer grads. I've worked in just about every setting that there is. I've done outpatient in multiple places. I've done skilled nursing. I've been a rehab director for skilled nursing. I've done home health. I've done acute care, oncology, done pediatrics, and I've taught in multiple PT programs, and I currently have a cash-based practice in the Florida area where I work mostly with gymnasts and cheerleaders. So kind of know a little bit about PT and the business side of it. So that's what I wanted to share with you today. So what I'd like to do now, if you're watching live, please go ahead and type live, whether you're watching on Instagram or you're watching in the Facebook group. Type live, tell me where you are, where you're watching from. If you're watching the replay, please type replay and same thing. Tell me who you are, where you're watching from. I'd just like to know who I'm talking to. So billing is a topic that I get a lot of questions about from students, especially students getting ready to go on clinicals. And then I get it from new grads as well, because it really creates a lot of confusion. It's just the billing. I get so many questions about how do I do it? Am I doing it right? How do I do it if this happens? So I think some of that comes from a lot of different things. So one, maybe clinics are, multiple clinics do it differently. I think sometimes clinics encourage some fraudulent billing habits. So if a student has been taught that way and now they're learning it a different way, that brings confusion. Generally, I think there's a poor understanding of it kind of altogether. And schools either teach it not very clearly or way too earlier in the curriculum. I actually do teach this stuff in a PT program local here. And I will be the first to tell you, I think it's taught way too early in their curriculum. And so that by the time they go on clinicals or they start working, they've already forgotten about it or things have changed. So let me know in the chat, whether you're watching on Instagram or Facebook, how do you feel about how you learned about billing in PT school? Drop a feeling word, like, was it clear to you? Was it confusing? How would you describe your education about billing while you were in PT school? So thank you for those of you that are sharing. As a student or a new grad, the idea of billing may kind of have you feel overwhelmed with knowing what codes to bill or how to correctly split up all of those minutes or how many units you need to charge for each code. Problem is, you've likely been given some really vague information about this or even taught some incorrect habits. That then makes you feel even more frustrated and confused about billing, and it makes complete sense that you feel this way. But I believe that you can learn the proper way to bill correctly and even learn some simple tips along the way that help it make a little bit more sense. As a new clinician or even a student on clinicals, you need to protect your license. And by using incorrect or fraudulent billing, that's a really quick way to lose your license. And nobody really wants that after all the time and money you've put into learning about being a PT. So this is just one of the topics that I help students and new grads figure out when I mentor them, and I want to share some of that with you today. So let's get started. Billing can be a very lengthy and deep topic, and today I don't have a ton of time. So what I'm going to do today is kind of just highlight some of the things, but I will touch on the very important highlights, okay? And if at any time you have any questions, you can always DM me and I can help you work through some of these questions. Okay. So we're going to start with the different types or modes of treatment that we can provide as therapists, right? So the first one, the obvious one, is individual, which is basically one patient at a time. That's it, right? Simple, makes sense. Then there's also concurrent therapy. And that is when you're treating two patients at the same time, but each patient is doing something completely different. This is most commonly seen in the skilled nursing setting, right? So you have one patient doing exercises on the mat, they're doing leg exercises on a mat, and you're doing gait training with a second patient, but you're seeing them at the same time, okay? So for it to be concurrent therapy, they have to be doing different things, okay? Second type or mode of treatment is group therapy, which everybody's heard about. Group therapy is kind of coming back. So group therapy is when you have 2 to 6 patients, right? And they're all doing the same activity at the same time. Again, this is most common in skilled nursing facilities. So you get, you bring 4 patients down to the gym, you've got them all sitting. Typically what you'll see for group therapy is, they're all sitting in their wheelchair and they're doing leg exercises. Not going to get into my thoughts on that. You can probably tell what I think about that, but that is one way to do group therapies. But for group therapy and skilled nursing, for Part A, Medicare Part A patients, group therapy means every patient has to be doing the exact same thing at the exact same time. In outpatient, group therapy can be billed for Medicare Part B patients. These patients can be doing different activities, but the therapist has to be providing some amount of that time, has to be direct, brief, intermittent personal contact with each of those patients, right? So in an outpatient setting, you can bill group if you've got 3 patients at one time. Maybe one person's walking on the treadmill, another person is doing, Therax of some sort, and another person is doing, I don't know, you're working on range of motion, right? Doing some manual therapy. So if you're seeing all 3 of them at the same time, but they're doing different things, that is group, but you can bill group for that, but you have to be spending a certain amount of time with each of those patients. You can't just be yelling out. You can't be doing all manual therapy while you're yelling at the one doing Therax. You have to spend individual time with each of those patients for it to be group therapy. For Medicare Part B, group. For Medicare Part A, group therapy, everybody has to be doing the same thing. Okay, hope that makes sense. All right. The last type of mode of treatment or treatment type is co-treatments. Again, this you'll likely see in skilled nursing or even some acute care. And that is when 2 clinicians from different disciplines are treating one patient at the same time. But their treatments have to be different. So one example would be like, let's say the PT and the OT, maybe they're working with a patient in the bathroom. The PT can be working on standing balance while the OT is having the patient brush their teeth. So they're doing an ADL in the bathroom. The PT can be working on balance by challenging, okay, let's do no hand, let's do one hand support, right? And then the OT is having them brush their teeth or brush their hair, brush their face. So there are 2 different disciplines working with the same patient, but doing different treatments, okay? For Medicare Part A, so skilled nursing or acute care, both therapists can bill for that entire time, but it needs to be documented why both were there, okay? For Medicare Part B, the time is either split between both therapists or one therapist bills all of that time. So it's very rare that you would bill a co-treatment for Medicare Part B patients because the math doesn't work out for revenue, right? So if it's a Part B patient and a PT and an OT are working with one person, either maybe the PT gets all of that 60 minutes or maybe the PT bills 30 minutes and the OT bills 30 minutes, but they've spent an hour with that patient. So you can see why it's not very good for a revenue standpoint, which is why it's not very common for your Medicare Part B patients. Way more common for Medicare Part A in your skilled nursing or acute care. Okay. Drop any questions. If any of this is confusing, I will definitely answer your questions. Okay. All right. Let's move on to CPT codes. Okay. The Again, I can't go into too much detail. I only have so much time, but I will scratch the surface of all this stuff and really highlight the important stuff, okay? The number one thing you need to understand with CPT codes, in my opinion, is knowing which ones are timed codes and which ones are untimed codes, okay? It's really important to know the difference, because that's how you know how to bill properly, and we'll get that we'll get down to that in a minute. But right now, I just want you to talk about the codes in general. So your untimed codes, these are your codes that get 1 unit regardless of how much time you spent with that patient on that treatment. So whether you did 15 minutes or you did 50 minutes, you can only bill 1 unit for the untimed codes. Now, some of the most common untimed codes are mechanical traction, your paraffin, your diathermy, whirlpool, infrared therapies, your hot and your cold packs, which, just side note, Medicare won't pay for hot and cold packs. So just side note there. Another common untimed code is unattended e-stim. So you put the e-stim pads on, you set the patient up, you walk away. If you're away for the entire treatment of that e-stim, that is unattended e-stim. Whether you spend 15 minutes with them or 30 minutes with them, you can only bill one unit for that unattended e-stim. Group therapy is also an untimed code. So we talked about those group therapy for Part B, only 1 code. So if you spent 60 minutes doing a group in that outpatient setting, you can only bill 1 unit of group therapy for each of those patients, even if you did a group session for 45 minutes. Okay. Timed codes are the codes that get 1 unit per 15 minutes. And we're going to come back to the minutes part. But right now, I want you to just understand the difference between the timed codes and the untimed codes, okay? Timed codes, some examples are your ultrasound, your iontophoresis, your laser therapy, your flutotherapy. Attended e-stim. So if you're sitting there with that patient while they're doing e-stim and you're monitoring them for something, the most common one I can think of is that functional e-stim. So maybe they've got weak dorsiflexor, so you're doing some functional e-stim to get the anterior tib to fire. If you're sitting there with them and cueing them, okay, every time you feel the e-stim come on, use that muscle, pull your toes off the ground. That becomes attended e-stim and it becomes a timed code, okay? And then all of your other therapeutic procedures, your TheraX, your gait training, manual therapy, your therapeutic activities, neuromuscular reeducation, all of those codes, those more common ones, those are all timed codes, okay? So if you're really confused on billing, the best place to start, make a chart for yourself. Which codes are untimed codes? Which codes are timed codes? And understand the difference between the two. Again, we'll come back into why that's important in a second when we talk about the 8-minute rule. Okay, now I want to briefly kind of scratch the surface, explain a little bit about these different therapeutic procedure codes, because sometimes what I see is clinicians or students are billing the wrong code for what was done. So you really need to understand what the definition of each code is so that you know where to bill properly, because if you're billing the wrong code for what you have documented, that is a form of fraud. And again, we will talk about that in a little bit. Okay, so right now, let's just define each of the different types of therapeutic procedure CPT codes. Okay, so we're going to start with TheraX, the most common one you're going to bill. The definition is any intervention used to develop strength, endurance, range of motion, or flexibility. So this includes active range of motion, active assisted range of motion, passive range of motion, stretching, and then any of your resisted exercises, therabands, weights, lifting, barbells, whatever, okay? So the one thing where I see some students and new grads get caught up here is the passive range of motion and the stretching. Some people will bill that as manual therapy, but it is not. If you do passive range of motion and you do stretching, that should be billed under TheraX, because by definition, that code is any intervention that's used to develop flexibility or range of motion. Okay. All right. So that's TheraX. Neuromuscular reeducation. That is used when you're providing interventions that improve balance, coordination, kinesthesia, or proprioception. So really any of your balance interventions are going to be billed under neuromuscular reeducation. But this is not just for your neuro population, right? You can bill neuromuscular reeducation if you're doing coordination or proprioceptive exercises for your athletes, right? Patient has this ankle sprain, you're probably putting them on an RX to do some strengthening, or you're working on the proprioception of that ankle, knowing where their body is in space. That can be billed under neuromuscular reeducation. The difference is how you've documented it, right? So if you've got your athlete who broke their ankle, they came out of a cast, and you put them on an RX, and you're documenting that you're doing single leg stance to improve ankle strength, then that would be billed under TheraX. Okay, does that make sense? If you put them on the RX and you're documenting that you're doing single leg stance to improve proprioception, then you're going to bill under neuromuscular reeducation. So documentation, I'm not really talking about it a ton today, but that's a huge part of correct billing, because what you're documenting, what you did, has to match what you're billing. Okay. Gait training. Gait training, the definition for using this code is direct one-on-one contact in the performance of progressive exercises or activities designed to improve the ability to ambulate safely and efficiently. This includes gait on any type of surface. So if you take them outside, or you have them walking on ramps, like level surfaces, unlevel surfaces, grass, sand, stairs, that's gait training. If you're teaching them how to use a specific assistive device, that should be billed under gait training. If you're teaching them how to ambulate with a new prosthesis or an AFO, that is gait training. Okay. If you're working to improve gait deviations, that is gait training. Okay. So anytime you're improving their ability to ambulate safely and efficiently, that should be billed under gait training. All right. Everybody still with me? Give me a wave if you're still with me, or a thumbs up. All right. Therapeutic activity. This should be billed for the use of functional and dynamic activities to improve or restore functional performance in a progressive manner. Basically, your bed mobility, your transfer training, car transfers, floor transfers, anytime you're pushing or pulling or carrying objects, throwing, climbing, catching, jumping. So a lot of your return to sport activities should be billed under therapeutic activity, because it's anything that simulates a functional activity. Okay. Manual therapy should be billed if you're using it to decrease pain, increase joint mobility, increase range of motion, or reduce swelling, right? Joint mobs, manipulations, manual lymph drainage, manual traction, soft tissue mobilization. Those are all manual therapy. Most commonly, you're going to see billed here is your joint mobs and your manipulations. You're decreasing pain, increasing joint mobility. Okay. Wheelchair management, let's talk about that code. So that is, you're going to use that code anytime you're assessing, fitting, or training a patient for a wheelchair. This includes doing a wheelchair evaluation to determine the correct wheelchair, the correct fit, the right type, determining accessories or parts to add to the wheelchair. If you're teaching a patient or a caregiver how to manage the parts of a wheelchair, how to take it apart and fold it or put it back together. If you're teaching them how to use the wheelchair, whether they're, how to use it going up ramps or around corners, pushing the wheelchair through a hallway, that is going to be billed under wheelchair management, as well as positioning in a wheelchair. A physical performance test. So this is used anytime. This actually is a code that I don't think gets used enough and can be used quite often. So if you perform a functional outcome measure like the Berg or dynamic gait or 4-square step test, if you do one of those tests, then you can bill it as a physical performance test, but you have to include written documentation of that test, so proof that you did the test, and then you also have to include documentation that explains the results of that test. So you can't just do a Berg and bill physical performance test. You have to do the Berg, but then also include in your documentation the results of the test and what those results mean. Then you can build physical performance test. Okay, I think that one often gets overlooked. I want to talk briefly about the different eval codes, because I think these have kind of gotten jumbled together in the past couple of years, and there's some confusion around them. So everybody knows there are 3 different eval codes, right? There's low, moderate, and high complexity. But the confusion comes in which one do you bill, right? So In order to figure out which one you're going to bill, you have to look at the patient's history, which includes all their comorbidities or their personal factors. Then you have to look at your exam. So how many different things did you test? How many elements did you look at? And then you look at the patient's clinical presentation, whether it's stable, evolving, or unstable, right? So each of those, you look at each of those three categories, right? Or factors. Of those three, you determine the lowest level. Now, Medicare's website has this all broken down. APTA's website also has a whole chart on it, so you can look there. But for each one, you find out where the patient falls. Is it low, moderate, or high for each of those factors? And then you have to build the eval code that has the lowest level, right? So let's say you had in the patient history, they were low, but you looked at a whole bunch of, you looked at like 10 different elements in the exam. So that would put them at high. And then let's say that their clinical presentation was unstable, right? So that would put them at that high complexity. So you have low, high, and high. You have to bill low for that eval code. It's the lowest of the three is the code that you're going to bill. That's where I see a lot of confusion, okay? Make sure you're billing the lowest one. On top of that, you may have also heard that you have to account for the time that you spend on the eval. This is not true. How much time you spend doing that eval has no impact on whether you bill low, moderate, or high. Okay. APTA does have like I said, they have a pretty nice graphic for figuring out the eval codes. And at the very bottom, it says it lists amount of time for the face-to-face time for that eval, but it has no impact on which code you're going to choose. Okay, I want to be very clear on that. The time that you spend doing the eval has no impact on whether you pick low, moderate, or high complexity for your eval code. Okay. How's everybody doing? Again, drop your questions if you have any, okay? Let's move on to the Medicare 8-minute rule. And this is the one thing, this is where billing issues tend to happen, okay? So today I'm just going to talk about the Medicare 8-minute rule. Remember, this is just for patients who have Medicare as their payer, okay? There are some private insurances that do follow that Medicare 8-minute rule, but you need to be aware of what the contract states for that private insurance, that for the facility that you're at, okay? And this is important because one facility may have a contract with Humana that's a completely different contract with another facility that has Humana, okay? So wherever you're working, ask your boss, ask your director, what does our contract say with these private insurances? Do I need to be using the Medicare 8-minute rule or not? Is there a different way, okay? So the 8-minute rule says for time-based codes, you must provide direct treatment for at least 8 minutes to be able to bill 1 unit of that code. That's the rule. That's all it says. For time-based codes, you got to spend at least 8 minutes of direct care to be able to bill 1 unit. Now there are 2 ways to figure out how many units you can bill for the total time that you spend with that patient. Okay. The first way, which is basically how Medicare does it, is you add up the total minutes that you provided one-on-one care for that patient. You divide it by 15. Okay. So let's make it simple. You spent 60 minutes with that patient, one-on-one care. You divide it by 15, you're going to get 4 units. Okay. If that's an uneven number, right? Let's say it wasn't 60, it was, I don't know, a different number. If there are 8 minutes or more left over, you can bill for another unit. So let's say you spent a total of 23 minutes doing manual therapy and Therax with a patient. If you divide 23 minutes by 15, you get 1. And then there are 8 minutes left over, which means you can bill 1 more unit. So the total units for that 23 minutes that you can bill is 2. Okay. The other way, which I think is a little bit easier, is to carry the Medicare 8-minute rule chart and refer to it. You can find this on Medicare's website. You can create it yourself, but this is basically a chart that breaks down how many units you can bill based on the one-on-one time that you spent with that patient. Remember, I hope you're hearing me say the one-on-one part, because for Medicare patients, you can only bill for time that you spent one-on-one with that patient. Cannot see multiple patients for Medicare and bill the full time. You can only bill the time that you spent one-on-one with that person. Okay, so like I said, you can look this up or you can make your own. So basically the chart is for 8 to 22 minutes, you can bill 1 unit. 23 to 37 minutes, you can bill 2 units. 38 to 52 minutes, you can bill 3 units. And for 53 to 67 minutes, you can bill 4 units. And then it does go into like 5 units, 6 units, and 7 units, I think. But I stopped at 4 because that's most common. Okay, so you can either do the math, right, in the first way, or you can just kind of carry that chart with you, total up how many minutes you spent direct one-on-one total time with that patient, and figure out, look at the chart, and that'll tell you how many units to bill. Okay, so how do you determine how many units go to each code, right? That's the other part that gets a little bit confusing for students and new grads, right? So an example, let's say you did 30 minutes of Therax, 15 minutes of manual therapy, and 8 minutes of neuromuscular reeducation. You have to start by totaling up all of those timed codes. So in this case, 30 plus 15 plus 8 is 53 minutes, okay? Then you can either look at the chart to figure out how many units to bill, or you can do the math. So let's do the math. So we had 53 total minutes of one-on-one timed care. Divide 53 by 15, and you get 3. Then there are 8 minutes left over, right? So 45 to 53 is 8 minutes left over. Because you have 8, that means you can bill another unit. So you can bill a total of 4 units for that patient. Okay. From here, you got to figure out how many go to each unit. Typically, you're going to give 2 units to the unit that you spent most of your time. So probably 2 minutes to Therax because we did 30 minutes there. Then 1 minute to manual therapy because you spent 15 minutes there, and then 1 minute to neuromuscular reeducation because you spent 8 minutes there. So that's how you can split up your 4 units, but you got to start figuring out what your total is. Okay. Remember, this is just for the time-based codes that you provided during the treatment session. So if you provided any other untimed codes during that session, those also get 1 additional unit. Okay, so let's look at an example. Say you did 16 minutes manual therapy, 32 minutes of Therax, 8 minutes of gait, and 15 minutes of unattended E-stim. How many units do you think you can bill? Go ahead and drop it in the chat, whether you're watching on Instagram or Facebook group. Tell me how many minutes or how many units do you think you can bill? 16 minutes of manual, 32 minutes of Therax, 8 minutes of gait, and 15 minutes of unattended E-stim. Okay, so first you're going to take the total of the timed codes. So we're going to add up 16 plus 32 plus 8, which is 56 minutes. Which you can look at the chart is 4 units. But you also get to add 1 more unit for that unattended E-stim because that's an untimed code. Okay, so you can bill a total of 5 units for that patient. Okay, let's do another example, and this one's a little bit more challenging, sneaky. So let's say you do 8 minutes of gait, 8 minutes of therapeutic activity, and 8 minutes of Therax. How many units do you think you can bill for this person? Go ahead and drop it in the chat. Okay, so you're going to start with totaling up what was your total time of timed codes. So we have 8 plus 8 plus 8, which equals 24. If you look at the chart or you divide by 15, you can only bill 2 units for this patient. This is a common mistake I see in the clinic. Okay, remember, it's the total time that you spent one-on-one with the patient. What I see happen a lot is clinicians want to bill 1 unit for each of those codes because you spent 8 minutes. So that would be fraud because you have to look at the total time, which in this case was only 24 minutes of one-on-one time So you can only bill 2 units. Then from there, you get to decide, because they're all equal, you get to decide which 2 codes you want to bill. Each code would get one of those 2 units. So you can pick 2 codes, each gets 1 code, 1 unit. Okay. Remember also, this is just for your Medicare patients, right? So some insurance contracts use a different method called the substantial portion methodology, which allows you to bill 1 unit in that situation, the 8 plus 8 plus 8. If the insurance company uses a substantial portion methodology, that says, that says you can bill 1 unit for each of the codes that spent a substantial portion of 15 minutes. So in that case, 8 minutes is a substantial portion of 15 minutes. So that one, you could bill 3 units. But again, these are more for your private insurance companies that use that methodology, not for Medicare. This is not the Medicare 8-minute rule. So it's a difference, and that's why it's really important to look and understand at the contracts for the insurance companies at the facility that you work at. Okay. So sometimes billing obviously can get a little hairy, especially in your outpatient clinics. So what I told you today is accurate. Okay. Sorry, excuse me. Everything I've told you today is accurate, but it can be really easy for this topic to get really gray and for clinics to encourage some unethical and illegal practices when it comes to billing. Okay. I encourage you to know the rules, understand it, how billing can be abused, and protect your own license. Okay. Real quick, I want to talk to you about some of the things to be aware of when it comes to fraudulent billing. The first one is upcoding. That is when you bill for a code that reimburses at a higher rate, even if you didn't provide skilled services for that code. This is one thing where I see clinics will tell their therapist, I want you to always bill this code. If your documentation does not support that code and you billed for a code that just pays at a higher rate, that's fraud. Okay. You should only be billing for the services that you provided, and your documentation needs to support that you billed that code. Okay. Another one is utilization abuse. This is basically when you're scheduling extra visits or providing unnecessary services. Sorry. The most common place that I see utilization abuse is when patients are coming in and they're just doing exercises on their own and nobody's giving them any skilled care, and the therapist bill for that TheraX. Patients coming in doing their own exercises and leaving, and you're billing for that, that's utilization abuse, which is fraud. You have to be giving skilled care, giving them cues, documenting that you've changed something. If you're not doing those things, they're just doing it on their own and you're billing for it, that's fraud. Okay. The last one is overcharging. And this is billing for services that you didn't provide or billing for more units than you provided. That one's really clear, obvious, right? Don't bill for things you didn't do. So if any of those 3 things are happening in your clinic, or your boss is asking you to do those things, this is a red flag. Okay. Protect yourself, protect your license. If these things feel fishy, do your homework, look it up, figure out what's right and do what's right. And if there's too many red flags, it might be time to find something else. Find a different place to work if any of those 3 things are happening. Okay. I hope you learned something new today. Please go ahead and drop it in the comments, whether you're watching on Instagram or Facebook. Tell me your aha moment or something that really stood out for you, or maybe something you learned. Tell me what you learned new today by watching. I want to thank you for watching, whether you're watching on Instagram or you're watching on Facebook, whether you're watching live or you're watching a replay. If you have any questions about anything that I talked about today, please feel free to DM me, message me, or just drop your question in the comments and I'll come back and answer them for you. Okay. Again, thank you for coming, and I will see you next time.